Okay. Thank you so much, Mustafa, for the kind introduction. Before I start, I would like to show my gratitude to the Pakistan Academy of Neurological Surgery for inviting me second time on this academic platform to talk to our future radiologists and future star neurosurgeons. Thank you for once again for having me.
Thank you for doing this for us.
Thank you. Thank you.
Gratitude.
Okay, so today we are going to talk. You can hear me clearly, right? So I don't need to use the headphone, right? So today we are going to talk about the posterior cranial fossa cyst, and it's going to be a snapshot of the key concepts. And as I said, it's going to be a snapshot. I'm going to make it as easy, as clear, and as concise as possible. So before I start, I have no conflicts and disclosure. Most of the cases are from my department, but some of the cases, information I'm taking from the open educational sites. And these are my main sites, and these are my book of references. And this lecture is inspired by the lecture of Dr. Kishman Kern, who presented the similar kind of lecture in ASPNR 2022. So when I was a resident, and whenever I used to see any MRI with posterior cranial fossa cyst, that's how it looks like. But actually at that time when I was a resident, it always looks like this to me. Everything and every head looks similar, every cyst looks similar, and it was really difficult for me to differentiate one from another. But what is the importance of doing the accurate diagnosis of each cyst, each cystic entity? Always remember, if you're a pediatric neurosurgeon, pediatric neurologist, or a pediatric radiologist, or a neuroradiologist, remember this in mind that the cystic malformations are very, very common thing in the pediatric population. And why the accurate diagnosis is important, it helps us in correct management of these different cystic lesions. The accurate diagnosis is needed for the prediction of the neurodevelopment of these children, and it determines the inheritance pattern with the risk of recurrence. And last but not least, it is very, very important for the geneticist to do according to the cyst, do the counseling for the further family planning and for the rest of the siblings. So we will start with the quiz number 1. This is the image, and this is, I'm going to tell you the findings. So it is saying there's a posterior cranial fossa cyst. This cyst is having a dilated fourth ventricle, normal size, and elevated, normal size and normal appearance vermis, but elevated one with a mild hydrocalculus. Considering these findings in your mind, what is the likely diagnosis in your mind? Is it a Dandy-Walker malformation? Do you think it's a megacystoma magna? Do you think it's a black pouch cyst? Or do you think it's a retrocerebral arachnoid cyst? Or you are thinking of the inferior vermeer hyperplasia? So let me launch the poll. It will take 1 minute. So I hope you all are able to see my screen. Okay. So far, almost 100% of you are thinking it's a Dandy-Walker malformation. Some of you are thinking, okay, so let's stop the poll. So currently, I'm going to show you the results. These are the results. So most of you are currently thinking of this thing as a Dandy-Walker malformation. Just remember your answers, and we will discuss it later in our lecture. So I'm not going to show you the results. We are going to discuss the results. So let's stop it and go ahead. So what I'm going to discuss today, we are going to have a review of important anatomical landmark of the posterior cranial fossa. We are going to learn a quick systemic approach to enlarge pericerebral CSF spaces or cystic structure of the posterior cranial fossa. And then I'm going to propose a systemic approach to review these main cystic pathology of the posterior cranial fossa. And in between, we are going to have a few quiz questions. So before I start doing the anatomy, embryology. As a pediatric radiologist, embryology is my favorite thing. Why it is important, as I said in my previous lecture, in your future life, how smart, how handsome, how beautiful, how successful you are going to be. It's not always depending on your circumstances, but it is also depending how correctly the sequencing and the alignment of your basic bodybuilding block was occur during your embryological life. So it has to be very, very correct to have a good, successful life. So don't worry, don't get scared with the word embryology. I know it's which the radiology resident don't like it, but I'm going to start from the 4th week of gestation and onwards, and it is when the neural tube gets closure. So after the closure of the neural tube at the 4th week of gestation, it divides or it forms the 3 main vesicles. The porencephalon, which is the cranial one, the middle one is the mesencephalon. So porencephalon makes in future makes the cerebrum, mesencephalon will make the midbrain, rhombencephalon will make the brainstem and cerebellum, and the distal part of this tube is going to be a spinal cord in the future. So as the brain further begins to grow, the porencephalon, this part divides into the diencephalon and the diencephalon, and the diencephalon will become cerebrum, and the diencephalon will become thalamus. There is no further division of the mesencephalon, so again, it's your midbrain part. But your rhombencephalon divides into the metencephalon and myelencephalon. The metencephalon will make your pons and the cerebellum. The myelencephalon will make your medulla oblongata, and of course, the distal part, as I mentioned earlier, is going to be your future spinal cord. So this is the quick review of the anatomy. But as we know, just focus on the rhombencephalon lip. By the end of the 7th week, just focus on this area, where the cerebellum and the 4th ventricle starts appearing. So if you just see this cleft, after the cleft, by the end of the 6th week of gestation, this is the appearance of the rhombencephalic vesicle or the hindbrain. So you can see your primary brain stem here, you can see your pons here, you can see your medulla oblongata, and the appearance of the 4th ventricle. This is the your cerebellum and the vermis area. So what happened? Just remember this picture, because I'm going to show this embryology picture again and again in my lecture with every case. So this is the picture of your brain at 6 weeks of gestation. So by the end of the 6 weeks, 2 membranes appear, anterior membrane area and the posterior membrane area. Very important, always remember these 2 membranes. Anterior membrane area is above the choroid plexus. This is your choroid plexus area and the posterior membrane area. So what happened at the end of the 7 weeks of gestation? This anterior membrane area start fusing or merged with the neural crest cells and start forming your cerebellum and the vermis. And your posterior membrane area, which is this area, which is below the choroid plexus, it's what happened. It is this membrane is start merging with the rest of the neural cells and start distending this area. When it posterior membrane initially, before getting the fusion and disappearing, start getting distension, this black pouch appear. This black pouch is a CSF, normal CSF containing pouch. At the end, between this 7th to 11th week of gestation, what happened after the distension of this black pouch? There's a small, you can appreciate the neck of this black pouch. So this neck of the black pouch gets the fenestration. And after the fenestration, this black pouch gets disappeared. And the neck of the black pouch is the foramen of McGinty. So remember, that's how a CSF start moving and going to connect with the rest of the CSF spaces. So remember your anterior membrane area, posterior membrane area, the black pouch, the neck of the black pouch, the fenestration of the neck of the black pouch, and then it becomes in future becomes the foramen of McGinty for the continuous CSF flow out of the ventricular system. So what are the types and cystic lesions? So I'm going to show you a very horrible slide. Don't worry. We'll try to make it as easy as possible. So there are the 2 types of cysts. The congenital cystic malformation. When I say it's a congenital cystic malformation, that means there's some problem in the embryological cascade, and you are having the cystic lesion in your posterior fossa by birth. Then there are the cystic lesions. So these are not the embryological lesions or congenital lesions. These can be either your inflammatory lesion, infectious lesion, or neoplastic lesion. So when we talk about the congenital cystic malformation, which are present in the brain by birth, they can be extracellular or they can be intracellular. And if I'm talking about this, not the malformation, but the cystic lesions. So as I said, they can be neoplastic, they can be inflammatory, they can be infectious, include hydatitis, epidermoid, and etc. So we are not going to touch the cystic lesions, which are the two acquired cystic lesions, because I'm pretty sure that this topic will be covered in your other lectures. So let's focus on the congenital cystic malformation. Then we have the two types, as I said, extracellular and the intracellular. If you talk about the intracellular one, we have the pontocerebral hyperplasia or any cerebral insult in prenatal life, such as ischemia or cerebellar hemorrhage, or, for example, the genetic abnormalities such as the dysglycanopathy. So all these conditions can lead the cyst with cystic lesion in the posterior corner fossa, but location is going to be within the cerebellum. But again, because of the shortage of time, I'm going to talk only about the extracerebral CSF spaces or pathologies, because these are the most common in our daily routine and especially in the pediatric population, but not only in the pediatric, in adults as well. So this is my lecture is going to be all about the congenital cystic extracellular malformations, and this mainly include the four entities we are going to talk on, which the Dandy-Walker malformation, the inferior vermian hyperplasia, Blake pouch, and the arachnoid cyst. So before we move on towards the pathologies, let's discuss the mid-sagittal anatomy, and this is very, very important to understand. The when we call the mid-sagittal plane, that remember, we are not talking about the cerebral hemisphere, we are talking about the corpus callosum, this appearance of the brainstem, and the cerebellum. This is the vermis, not the cerebellum, though, but the part of the posterior fossa. So this is your corpus callosum, your midbrain. Down the midbrain is your pons, and it's your medulla oblongata. Behind the midbrain, here it is your tectal plate. This is your fourth ventricle, this triangular shape. And this fourth ventricle distally connecting with the spinal canal through the orbix. So this is your gross or main points in the main anatomical areas in the mid-sagittal plane. Now, what are the important anatomical landmarks? And now the slides I'm going to show you, you are allowed to take the pictures of those, because it's going to help you a lot in your daily practice. So this is the area we have already discussed. Now let's focus typically on this area. Let's have a magnified view of this area. So again, your corpus callosum, your brainstem, and the vermices are here. So let's talk about the anatomical landmark for the normal tentorium orientation. So always remember, let me move on this. Yeah. So normal tentorium is having the 45 degree. It always make the 45-degree angle with the brainstem. You can see that's how we draw the angle. The normal insertion tentorial point is the trochlear. Remember, the trochlear is the venous sinus confluence. It's the confluence of the straight sinus and the sagittal sinuses. And it has to locate it at the inferior portion of the tentorium. So if your tentorium is here, so this is your trochlear. If you see the trochlear, assume your tentorium is here. And then we always talk about the torcular and lambdoid relationship. Most of the time it is seen on the CT scan, but sometimes you are able to see the lambdoid suture, especially in the children. So always remember that the trochlea is always below the lambdoid suture if you are able to see that. So now we have just talked about the tentorium, normal anatomical landmark. Let's talk about a few words about the fourth ventricle. So remember, this red triangle is your fourth ventricle. It's having the fastigium. Fastigium is the pointed part of the fourth ventricle, or you can say it's an extension of the fourth ventricle within the vermis or cerebellum. Remember this angle. It's a key angle. Okay. So tegmento-vermian angle. Normally, that's how we draw the tegmento-vermian angle. You draw a straight line at the posterior surface of the brainstem and the anterior surface of the vermis. So tegmentum and the vermian angle they always are the parallel lines. They don't make in the normal person. They will never make any. They will never make any angle. So whenever there is an angle more than 10 or 30, or especially if it is more than 40, it's always abnormal. So now, you know about your tentorium landmark, you know about your fourth ventricle appearance, you know about your tegmento-vermian angle, which should be 0. Now we have talked about the fourth ventricle, another important structure in the posterior flank fossa, which is the vermis. So this is, as you know, it's our midbrain, pons, and the medulla. I'm sorry, I'm not going to jump on that. I'm going to talk about the brainstem. So if somebody tells you about there's a brain stem dysplasia, there is a mass or anything, or you think that brain stem is abnormal on MRI, it is not a subjective evaluation. Always remember, it's your objective evaluation. And we do this objective evaluation through these measurements. So it's just a gross way. That's how I remember it, that the length of the pons should be twice that of the midbrain and the medulla. And that's how I look at it. And remember, when we draw a line posterior to or just distal, this is your cerebral aqueduct. If you draw a straight line just distal to that till the orbix, it should be as always a straight line. If you see any irregularity in this line, always suspect some abnormality in the brain stem or mass effect or anything, but it's not your normal brain stem. Last but not least, the fastigium, the triangular part, this pointed portion of the fastigium, if you draw a straight line through this, always remember it should pass below the midpoint of the pons. So if it is the midpoint of the pons, it should pass below that. If this fastigium is high, always suspect the brainstem abnormality. So now fourth ventricle, brainstem, and tentoriums are done. Another important structure in the posterior cranial fossa and sagittal view is the vermis. So vermis is divided into the cranial, middle, and the caudal lobes by the primary fissure. This is your primary fissure. You can see a primary fissure here, and the prepyramidal fissure. And just look at the appearance of the fissure. And this is the future slides are going to focus on the vermis only. So remember, this is the primary fissure, which divides the vermis, especially into the two broad halves. The upper half, this is any part of the vermis which is anterior to the primary fissure is the anterior portion of the vermis. Anything, the two lobes which are posterior to the primary fissure, it's easy to remember the primary fissure. So that's the reason I'm just showing you the primary fissure. So the part of the vermis which is behind this primary fissure is it's known as your posterior vermis. So anterior vermis and posterior vermis. So when we suspect a vermian pathology or vermian hypoplasia, how do we do that? So again, what is the way? So always remember this, your posterior, it's always having the 1:1.5. So it is the posterior vermis is bigger than the anterior vermis. So just a corresponding image of an abnormality when we have a vermian hypoplasia, you can see vermian hypoplasia, the posterior part of the vermis, which is posterior to the primary fissure, is smaller than the anterior part. And in a normal condition, it should be more than that. So if it is a small one, then you always suspect the vermian hypoplasia, and this results in the enlargement of the posterior cranial fossa area. Don't worry, I'm not going to talk in detail about the cerebellum. It's just going to be a quick few important points which I want you to remember. This is your cerebellum, just magnified this area. So remember this midline structure. So this is the appearance of the vermis, which is central in the axial view. It looks like this, and is smaller in size than the cerebellar hemisphere. Remember the contour of the cerebellar hemispheres are always smooth. And can you see these black lines, the lines, they always go along parallel to the calvarium. So this is what you really need to remember and forget about the rest. So now I'm going to show you the systemic approach to the enlarged posterior cranial fossa cystic spaces. So it's going to be a six question based approach. Number one question, we will see either the vermis is normal or abnormal. The question number two is going to be the fourth ventricle, either it's enlarged or normal. Question number three is going to be either the tegmentovernian angle is normal or not. The fourth question is going to be the posterior fossa, either it's enlarged or not, and hydrocephalus is present or not. A last sixth question will be the occipital bone scalloping or any abnormality in the contour of the posterior fossa, especially the occipital bone. So remember, this is my proposed 6 question based approach to the cystic lesions in the cranial fossa, posterior cranial fossa. So now let's explore our first case with this approach. So this is the patient who referred to us from the neurosurgery clinic. He was a 2-year-old boy with increased head circumference. What do you think? It's a normal or abnormal? Definitely looks abnormal, but to call it a normal, you always must have a reference mid-sagittal image, always in your mobile phone, on your tabs, on your clinic, whenever you are, or in your reporting area, whenever you are evaluating. See, if you compare this area, the cystic area from the posterior, this is a normal. If you compare it with a normal, then definitely it's an abnormal. So now let's explore this case further with our 6 question-based approach. So what do you think about the vermis? So look at the vermis, and this is the normal appearing vermis. Is it a normal vermis or not? Absolutely, there's a hypoplastic vermis. Second question, The fourth ventricle, is it enlarged and abnormal? Remember this fourth ventricle triangular one? This is the large and open fourth ventricle. Coming to our third question, tegmentovermian angle. This is how it should be 0. If you measure it, the tegmentovermian angle is definitely more than 40, and that's how you measure it. Our fourth question, posterior fossa enlarged or not? Definitely, if you compare with this, it is the enlarged posterior gland fossa. Your fifth question, hydrocephalus is present or not? If you see, this is your normal ventricular system, and if you compare it, definitely it's an enlarged ventricular system, hydrocephalus is present. Your sixth question, the occipital bone scalloping is present or not? You see this black line, this is the scalloping. So really the bone scalloping is, though it's enlarged fossa, but scalloping is not there. So all the answer of these 6 questions, these are the characteristic features of the classical Dendy-Walker malformation. So if you have all these findings, you're diagnosing the Dendy-Walker malformation. And always remember that the torcula and the lambdoid relationship is always reversed, especially in cases of classic Dendy-Walker. It gets up, you can see the torcula up and the suture is down here. That's what we are talking about when we say there's an inversion of the lambdoid and torcula relationship. So just go back to why this malformation happens. Remember this slide, which just give me a minute. I'm having this problem with this area. Okay, so remember this slide. I'm not going to detail again. Because of any abnormal genetic mutation, any intrauterine intraventricular hemorrhage or prenatal skimming insult to the cerebellum can result in cystic malformation. And what happens when it happens in the prenatal life? Remember your anterior membrane area. So remember, whenever there is a defective absorption of the anterior membrane or the posterior membrane area, especially this area, in intrauterine life, this becomes the abnormal formation of the cerebellum and the cerebral cerebral hemisphere and the vermis. So it depends about the severity of the insult, and because of this insult, you receive this kind of picture of big fourth ventricle. So that is the cause of the Dendy-Walker malformation. So whenever you have this much large cystic area, always remember, always, either as a neurosurgeon, you expect this severity of the hydrocephalus and the mentioning of the supratentorial, or if you are a radiology resident, remember that you need to mention the presence of the hydrocephalus and the supratentorial abnormalities, because their neurodevelopment outcome is totally going to be depending on the associated abnormalities with that. Coming to the question number 2, female, 7 years old, presented with the headache in neurology, pediatric neurology clinic. What do you think? Is it normal or abnormal? So calling it an abnormal or normal, you always need a reference, as I said, the reference image. So if you compare it, to, definitely the posterior cranial fossa as compared to the normal image definitely looks abnormal. So again, let's explore this case with a 6 question-based approach. What do you think of the morphology of the vermis? So this is your normal vermis. If you see, so we can see a cyst here, but this cyst is causing push or mass effect over the inferior vermis. So it is normal in size, but it's pushed by the cyst. Your second question, the fourth ventricle, this fourth ventricle. Fourth ventricle is enlarged or not? Definitely fourth ventricle is enlarged. Your third question, tegmentovermian angle, which is always 0. Definitely it is more than 30, or it is at least more than 0. Your fourth question, posterior cranial fossa is enlarged or not? So there is a mild enlargement of the posterior cranial fossa as compared to the normal. Your fifth question, hydrocephalus is present or not? So if you compare it with the normal, definitely there's a hydrocephalus is present. And your last 6th question, is there any scalloping of the occipital bone? The answer is no. So all these 6 answers are making the diagnosis of the black pouch cyst. Why the black pouch cyst again? Again, remember this slide, the anterior membrane area, the posterior membrane area, the black pouch. So remember, as I mentioned earlier, the black pouch forms in the 6 weeks of life. And before the fenestration of the foramen of Meganti, you have this dilatation of CSF space, which is the black pouch. So if there is any defective absorption of the posterior membrane area this area occurs, there's an incomplete perforation occur of the neck of this black pouch. This results in the blockage at the level of the foramen of Meganti, and here you see this herniation of this pouch through the inferior vermian space. So that is the embryology of the black pouch cyst. So initially I asked about this image, and most of you were thinking of the Dandy-Walker malformation. So now it was not the case of the Dandy-Walker, it was a case of the black pouch. So in cases of the Dandy-Walker, remember the severity of the Vermeer hyperplasia? So this was the answer of quiz number 1. Now here comes the quiz number 2. What do you think? Is the black pouch a brain malformation? Yes, no, or you are not sure. And here comes your quiz. No, this is the only way that we can make this lecture a little bit interactive. So what do you think? No. Wow. Okay. Okay, good. So people are still voting. Okay. So now almost more than 80% people have. Okay, people are changing their answers as well. You're not allowed to change your answer once you have given. So let me show you the results. So most of you are thinking no, which is actually a correct answer, but 32% of you are thinking that yes, this is an abnormal brain malformation. So let's see the correct answer. Okay. Okay, so black pouch is not, remember the term, the black pouch itself, remember, it's not a malformation, it's a normal embryological structure. So what I want all of you to remember, whenever we talk about the black pouch, it's a normal structure. When we call it a normal structure, when you don't see any rotation of the worm. But if you see a cystic area, and remember about the black pouch, as a pediatric radiologist, and especially the pediatric neurosurgeons are familiar with this, okay, it's a normal finding, especially when we are evaluating the prenatal fetal MRI, or especially in the neonate till the age of 3 or 4 months. So inferior black pouch cyst may persist in normal individual, and it has no clinical significance if it is not causing any mass effect or the hydrocephalus. But remember, the term black pouch cyst is a different thing. So how do we differentiate the black pouch with the black pouches? The only thing we tell you is the rotation of the vermis. If there is a cystic area, vermis is fully formed, but it is rotated, you think of the black pouch cyst rather than simple, a normal variant black pouch. It's a very important landmark to remember. And overall, you remember, if you have this, don't worry about it. Overall, they have the good neurodevelopment outcomes. Coming to the question number 3, female with a headache. Again, the neurological patient. What do you think? What's going on? Is it normal or abnormal? Remember, to call it an abnormal, you need to have, oh, sorry. Okay. So call it an abnormal, you need to have a reference image. If you compare it with the reference image, absolutely abnormal. Let's explore this case with a 6 question-based approach. Again, I know you will get tired of this approach, but at the end, you will remember this. So vermis morphology, what do you think of it? Normal, if you compare it with the normal vermis, definitely it's an abnormal small size vermis as compared to the normal one. Number 2, question number 2, fourth ventricle. The fourth ventricle is definitely enlarged as compared to the normal ventricle. Question number 3, tegmentovernian angle. Definitely tegmentovernian angle is abnormal, is enlarged. Question number 4, posterior fossa. It's enlarged small size. Of course, we have a cyst, but the enlargement is not there. It is no. Answer is no. Do you think that hydrocephalus is there? So if you compare this system with this system, of course, except for the magnification of mate, there's no hydrocephalus. Your 6th question, the presence of the occipital bone scalloping, present and not. Here it is your black area bone. The answer is no. So all these questions, answer of these questions are making, these are the characteristic features of the isolated inferior vermian hypoplasia. So there is a small, the inferior vermis is absent. And then because of that, you have this space. So again, remember, go back to our embryology, this slide again, the anterior membrane area, the posterior membrane area. So I'm not going to do the detail. Remember, whenever there's a defective anterior membrane area resorption, posterior membrane is area resorption, either it's, if it is severe, it's going to be a Dandy-Walker malformation, or if it is mild, then you have only the small form of malformation of the vermis. Remember your anterior membrane area and the posterior membrane area and the severity of the malformation. And again, most of the time people were talking about, especially in the pediatric neurology meeting, people always talk about its clinical significance, the their outcome, the clinic neurodevelopment outcome is still controversial. Some studies says they are the normal individual, it's incidental finding, and some say that they may have the mild functional deficit, especially the fine motor activity will be weak in these individuals. So again, I'm not going to detail of that. So here comes your question number 3 regarding, I've shown you the black pouch. I have shown you, except the megacisterna magna, I have shown you the black pouch, the classical the complex, the classical Dandy-Walker malformation, and the black pouch cells. So my question is, do you think are the terms we have always used these terms, the Dandy-Walker variant, the Dandy-Walker complex, the continuum? Do you think these terms are appropriate to define the black pouch, inferior vermian hypoplasia, and the megacisterna? What do you think of it? Please let me know your answer. So I need to see what is the clarity about these terms. What do you think? Should, instead of using, when we have these abnormalities, should we use this word in our daily practice, clinical practice? Yes, no. Because I have used this term many times in my reports. Okay, so I am ending the poll. Around 80% people have voted. Now, let me show you the results. So most of you, I hope you are able to see the results side. So most of you, the 60% of you are thinking, no, these are not the correct terms to define these entities. But the 26% of you are still thinking, yes, we can use this term. So let's see what is the correct answer. The answer is no. Why? Always remember, in the past, these terms were created to differentiate those posterior fossa cystic malformations that were not fulfilling the criteria of the classical Dandy malformation. So when in the past, we used to have the isolated vermian hypoplasia or black pouch remnant cyst or megacisterna magna. So we used to use word the Dandy-Walker malformation, variant, continuum, or complex. So remember, the Osborne and the Barkovich, which we as a radiologist know that these are considered as the father and the pioneer of the neuroradiology, they strictly recommend that please stop using these words. These are the ambiguous terms, and they always create the confusion for the surgeon, for you yourself, and especially for the geneticist. Because geneticists, he doesn't know how to do the counseling for this and how to predict the neurodevelopment outcome of these patients. So stop doing it. So if you have, and you are not having the classical features of the Dandy-Walker malformation, your interpretation tip is use clear description and the best categorization of abnormal posterior fossa finding when possible, which is most of the time is not challenging. It's quite challenging for us, but a complete anatomical description is very important instead of using these terms. Coming to the case number 4, this patient presented is around 18 years old boy who presented with the meningitis and fever in emergency room. We performed the MRI and this is the image. Do you think it's a normal? At once, it looks absolutely normal to me. But if you compare it with abnormal, yes, there's an abnormal cystic area in the posterior cranial fossa. So what do you think of it? If you compare it with the normal, definitely there is something wrong in the posterior cranial fossa. So let's explore this case again with our 6-question-based approach. Do you think the vermis is normal if you compare it with the normal vermis? It absolutely looks normal. Do you think fourth ventricle is abnormal? Absolutely normal, comparable to the normal. Tegmentovermian angle, again 0. That's mean tegmentovermian angle is absolutely normal. Posterior fossa, enlarged or normal? It looks normal, except the cystic space, if you see in the normal, is not there. Hydrocephalus, no hydrocephalus. Occipital bone scalloping is present or not? What do you think about it? Is there or not? You think of it and then let me know your answer. So if you see this is the black line, so you see it's not there. So if you have none of these 6 findings, but only you have this small area, then what do you think? You always think of the megacisterna magna, which is a normal variant. And why it happens, again, remember our embryology slide, whenever there is defected or delayed in the perforation of the neck of this black pouch, we have this formation of the megacisterna magna, absolutely an incidental finding in most of the cases. This area I'm talking about. they usually have an excellent prognosis and it has no clinical significance. So coming to the last case, what do you think? It's a male, 17, presented with the migraine, and he was complaining the postural headaches. The migraine was the postural headache he was complaining. What do you think? It's abnormal or normal? What do you think of this image? And calling it abnormal, you need to have a normal one as a reference. So if you compare it with the normal one, you will have definitely abnormal cystic area in the posterior fossa. So again, let's explore this case with our 6 question-based approach. Talking about the vermis, is this the vermis is normal or abnormal? So if you focus on the size of the vermis, it looks normal beside, but this cystic structure is in the posterior fossa is pushing it, causing the mass effect over it. If we talk about the fourth ventricle, if you look carefully, the fourth ventricle absolutely look normal in size, but again, it is having the mass effect because of the cystic structure in the posterior fossa. If we talk about the tegmentovermian angle, again, the tegmentovermian angle is absolutely normal. If we talk about the posterior fossa, so yes, there is a slight enlargement of the posterior fossa. If we talk about the fifth question, number 5, the hydrocephalus, yes, hydrocephalus is there, and probably this is the obstructing kind of hydrocephalus because this cyst is causing a mass effect over the cerebellum and the vermis and fourth ventricle, resulting in proximal hydrocephalus or dilatation of the ventricular system. And your last question, occipital bone scalloping. Now compare this black bone with this bone. So you can see the thinning. So all the questions are negative except the hydrocephalus, the cystic structure, and the scalloping of bone. This area I'm talking about. So it is making the diagnosis of arachnoid cyst in the posterior fossa. So remember, this is not why this occurs. It occurs because whenever there is a duplication of arachnoid space in the posterior fossa, you always have the arachnoid cyst. So this is again a very important thing. When this is the finding whenever they have, the neurosurgeon will come into the reporting area, or you as a neurosurgeon will come to us, and you will always have a confusion when they are, most of the time they are asymptomatic, but if they are symptomatic and you want to surgically remove these cysts through these different procedures, you really want to make sure either you really need to go in or not, because it is a close mimicker of the cisterna magna. So if you have your neurosurgeon comes, or if you as a radiologist or as a neurosurgeon, you have a confusion, either you are dealing with the cisterna magna or arachnoid cyst, what will be the next imaging modality of choice, which as a radiologist you will recommend, which as a neurosurgeon you are going to ask to us to? Do you think it's going to be the MR spectroscopy to differentiate between these two? You think it's a MR cysternography you're going for, or you think it's a cysternography, or you will go for the MRI CSF flow study? And with that, here comes your quiz. So how you are going to investigate further when you are confused, either before the surgery, it's an arachnoid cyst or it's a mega cisterna magna. I really want you to see this. And we are doing it in routine and AKU. So almost, wow, very quick. So interesting results. So I'm ending the poll. We have 30 seconds are over. I'm going to show you the results. The majority, 58% of you are thinking about the MRI CSF flow study, but there are the people who are still thinking, okay, sternography, cysternography, or CT cysternography as well. Let's see what is the correct answer. Let me close my quiz. So correct answer was the MR CSF flow study. So as I have mentioned earlier, the mega cisterna magna and the arachnoid cyst are the close mimicker of each other, and that's how it looks. It appears like this. So whenever before the intervention, any neurosurgical intervention, you want to make sure that you are not dealing with the cisterna magna, but you are going to remove the arachnoid cyst. You always ask for the CSF flow study. So this is how the CSF flow study looks like. So one is in phase and the other one is out phase images. Forget about these names, but remember, can you see this CSF black area and the rest of the CSF spaces? If you see, this is showing the continuation with this cystic area. This is the cystic area, and you can see the continuation. So this cyst is continue with the rest of the CSF spaces. So this is your mega cisterna, and you don't need to do any surgical intervention because you're not going to remove anything. It's just a space there. But if you have this, again, the similar cystic space, and if you see Can you see all the CSF spaces are white here, 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 and this cyst is not showing any continuation with the rest of the thing. That's mean this arachnoid cyst is not showing the continuation because it's not a normal CSF duplication space. So that's when you're dealing with the arachnoid cyst. I still remember this 45 years old male, and that was a case of you, Dr. Atharnam. Do you remember this has been discussed in the neurology Thursday meeting as well, when he really wanted us, and he really wanted us to put the addendum, and he wanted to be sure that, yes, make sure that size is okay, and I'm dealing with this posterior cranial fossa cyst and how much obstruction it is causing. So when we perform, this is one of our very rememberable case when we saw this cystic area. You can see the posterior cranial fossa, and you can see all the CSF spaces are bright, but this area is not showing any communication on the cystoscopy. So probably, Dr. Thur, you have reported. So this was discussed in the Thursday meeting, and I still remember the great discussion over this case, okay, how to go further and how to investigate further. So it is the one of the examples when we discuss and explore the cases as a single team. So this is going to be the last academic question, though we have another quiz question. For the cystic hindbrain malformation, the degree of the neurodevelopmental delay and the cognitive outcome are related to which thing, which appearance? The dysmorphism of the hypoplastic vermis, it depends on the supratentorial anomaly, or it depends on the severity of the hydrocephalus, or all of the above. What do you think? And let me know your answer. So how, as a radiologist, neurosurgeon, neurologist, you predict their clinical outcome, neurodevelopment outcome? So I will not take much time in it because everybody, oh God, oh, it's just stopping. So 100% of you, not the 100%, oh, people changed. So 90%, majority of you are thinking that all of the above, and some of these of you are thinking of the severity of the hypothalamus. Now see, let me stop the sharing this result and see the answer. Remember, always remember, as I said earlier, look again and again whenever you have any malformation or cystic structure in the posterior cranial fossa for other structure, other abnormalities as well, because it's always depend not only on one thing, all of the above, because it depends on the progression of the hydrocephalus, how much parenchyma is there under the pressure, abnormal parenchymal abnormalities such as the abnormal cerebellum, vermis. Look again and again and again, additional supratentorial abnormality, which includes a corpus callosal agenesis or structural malformation such as polymicrogyria. So remember, this is the case which we have discussed in our meeting in January or February, I believe. So this was a baby who presented to us. So you can see there is a abnormal black pouch. But in addition to the black pouch, there's definitely abnormal dysmorphic cortical gyri and pattern, gyri and sulci, and you can see the dysmorphism of the cerebellar hemisphere. So these are the patients who are not the isolated cases of the black pouch. Look again and again in other findings to predict the neurodevelopment outcome and suspect the chromosomal abnormalities in these children. Another case, unfortunately, this child presented last week in an ICU, and we have also presented yesterday in our grand round as well. So this child, poor baby, presented in an ICU with abnormal facies. We did the MRI and we found there's an inferior vermian hyperplasia. But look at it, this inferior vermian hyperplasia is not an isolated finding. When we look again, so in supratentorial, we can see there's an absence of the corpus callosum. There's an abnormal pattern of the gyri. So it's a diffuse polymicrogyria pattern. If you are really interested to see the want to see how it looks like. So that's how the pachygyria or the polygyria pattern. So 3 findings: abnormal inferior vermis, abnormal corpus callosum, abnormal supratentorial parenchyma. So again, the we mentioned, we discussed this case, and with the consensus after the meeting, it was decided to electively withdraw the respiratory support. And unfortunately, over the weekend, this child died. So as I said earlier, when I started, it's going to be a quick conclusion and a snapshot of the posterior prognosis. So this is the a snapshot of the images, and I'm really grateful, Dr. Kishman, for providing me this slide. And I strongly recommend all the neurosurgery resident, neurology resident, and the radiology resident, whenever you are doing the interpretation of the scan for the posterior cranial fossa cyst, keep this thing in your mobile phone, tablet, or your reporting area, or in your clinics. Whenever they have, always look for the vermis, fourth ventricle, posterior fossa, hydrocephalus, and tegmental penangle. I'm not going to the detail because we have discussed all this in the detail. So it will definitely, this chart will definitely help you to make